Okay, this being said, this was the first answer I wanted to address. Why are most of you feeling not depressed? The second one is, what is depression? And to be honest, I'm for a few decades in the depression field, and it's more and more difficult for me to give the right answer. I could say, make it very easy and say, if you fulfill the DSM criteria for major depression, then you suffer from depression. That's the easiest way. But that's a problem, because DSM, as you all know, Diagnostic and Statistical Manual, some people say this is not Diagnostic and Statistical Manual, but it's a diagnostics for simple minds. Or some would even say diagnosis as a source for money. If you want to get a grant, you have to have a DSM diagnosis. So DSM, the question is this useful or not? Is this all the depressive symptoms? You know, I could have my phone and ask you questions. That would be the better option. How many depressive symptoms do you know? Probably many more than these 9. Well, the 9, you all know, depressed mood is the number 1. Okay, reasonable, fair. But nothing is said about the lack of positive mood. And of course, some people still might think that positive mood and negative mood are highly negatively correlated. Well, this is just not true. Most studies looking at the correlation between positive mood, of changes in positive mood and changes in negative mood, have correlation coefficients of about minus 0.40. That means that about 16% of the variance in the one is linked to the variance in the other, which means that 84% is independent. So this is a shame, it's not in it. The second one, very important, remember it because I'm going to come back on it, diminished interest and pleasure. That's the hedonic function. Anhedonia. That is very important, as I'm going to show you, and is often forgotten. Interest in pleasurable things and taking pleasure from things. This is anticipatory hedonic function, consummatory hedonic function. And then you have all the others. And then there should be clinically significant distress or impairment. And again, we could discuss probably, and we would have a lot of various opinions, what is clinically significant here. But there's problems with these definitions, and one of the problems is that if you have to have 5 out of the 9 symptoms, at least theoretically you can have 2 patients who have only 1 symptom in common if I go back. The first patients could have depressed mood, and then 2, 3, 4, 5, and the second patient could have diminished interest, and then 2, 3, 4, 5. 1 symptom in common, or even 0, because the one could have increased appetite and the other one decreased appetite, which is not exactly the same. That's a problem. That means also 5 out of the 9, that makes that there is such a heterogeneity in a patient population of depressed patients that if you do a little bit of permutations, I don't do that, but these authors did, then you end up with 227 unique profiles, and we all call them patients suffering from major depression. If you have a fracture of your femur, that's more easy. That's one-on-one. Cutting down sleep, appetite, and the psychomotor changes, retardation, or agitation, then you end up with even 945 unique profiles. And when they were looking in STAR-D, I said the 2 core criteria, depressed mood and anhedonia. Well, in STAR-D, about 20% of the patients had anhedonia but not depressed mood, which in the older literature has sometimes been called being depression without depression. But as I said, you being good clinicians, you have many more depressive symptoms, you know. And then we move from diagnostic items to symptoms as we assess them with scales. And then you get a huge variety. You all know most of these scales, probably I don't go into them, but if you look at observer rating or self-rating, DSM is of course 9, and the PHQ is the mirror picture, but self-rating and is again 9. But you have the Hamilton, that's 17 or 21 or 28, depending on the version. The Madras is 10, the IDS is 30, John Rush scale. So there's many more symptoms if you want. And self-rating, hospital anxiety and depression scale, the depression subscale is 7. And you can go to the IDS self-rating, which is 30, and even the Carroll 52. And I'm afraid that these questionnaires do not reflect, in fact, what the core of depression is. I'm going to show you, because my next question to you could be, what is now, in your opinion, the most specific depressive symptom? And with specific, I mean the one that differentiates best depression from other mental disorders. I'm going to try to illustrate that in one way just by putting some emphasis, and that's why I put it in red here, the CES-D. The CES-D is the Center for Epidemiological Studies Depression Scale. It's a scale that is often used in epidemiological trials just to find out, to pick out cases for depression. And the good thing about that scale is, as you can see here, 20 items, but at least 4 are about positive mood, because most of the scales don't have anything on positive mood. They have 4. I felt I was just as good as other people. I felt hopeful about the future. I was happy and I enjoyed life. So 4 out of the 20 have to do with positive mood and 16 has to do with negative mood. Okay, what these authors did then with this scale, and that's interesting, and that's what I share with you, Olsen et al. Well, what they did is here, column 2, the second column here, this is the sum of the 16 items that were to negative mood. And the red in the third column here, that were the 4 items that were about positive mood. And then they had a patient population, and they looked at dimensions of psychopathology, and that were somatic complaints, anxiety, depression, mania, paranoia, schizophrenia, borderline features, antisocial features, alcohol problems, and drug problems. And they looked at the sum of the negative affect items, or the sum of the positive affect items, to what degree do they contribute to these different dimensions. And what do you see? Negative mood is very aspecific because it contributes to somatic complaints, to anxiety, to depression, to mania, to paranoia, to schizophrenia, to borderline features, not to antisocial features. We heard about anxiety. I always ask, so is there somebody who dares to say in the audience that they are never fearful, never have anxiety? Then they probably have antisocial personality disorder. So never say that. And alcohol problems and drug problems is also very low, as you can see here. But it's very aspecific. It contributes to everything. While the 4 with positive mood, they just contribute to mania and depression. Only to the mood disorders. So in fact, this suggests, and there's other studies that I could show, but this suggests that maybe the most specific, I'm not saying the most important, but the most specific depressive symptom is anhedonia. Once we have depression, we have to think about the consequences of depression, the impact, the burden. And usually then it's calculated how much it costs in financial terms. And you see astronomical amounts of direct and indirect costs. What we tend to forget, we being psychiatrists, is that depression kills. And of course, you probably agree with me, hopefully you agree with me, and you think about suicide. But suicidal mortality is only a minor thing. It's important, of course, but it's a minor thing. If you look at the increase in mortality in patients suffering from depression. This is Australian data. I had to at least have one slide with Australian data, of course. And this is the one. This is taken here just looking at life expectancy in men and women from 1985 to 2005. And you see here that the red dotted lines, this is for people with normal mental health. What do you see? What you all know, that women live longer than men, that there is still an increase in life expectancy between 1985 and 2005. But then the green lines are in fact the lines for patients suffering from major depression. And this is dramatic. The reduction in life expectancy is about 10 years in women and it's about 15 years in men. This is dramatic. And suicidal mortality is only a very small portion of that gap. Because it has been shown, indeed, that depression reduces life expectancy. And then the next question is, of course, but what is it in depression that reduces it? Is it the changes in sleep, the changes in appetite? Is it feeling worthlessness? Or is it the lack of positive mood? Or is it the excess of negative mood? Well, and the Step 2's group, they did a meta-analysis, and you see it's 35 studies taken all together. And what they could show is that this is for healthy people, 35,000, this is for a disease population. Disease population was diabetes, was rheumatoid arthritis, cardiovascular issues, etc. What do you see? Well, that in fact, positive mood is protective, significantly protective, as well in the healthy population as in the disease population, even if in your modeling you take into account the negative mood. So the lack of positive mood kills more than the excess of negative mood. Remember what I said about health promoting behavior, for example.